Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Professor, Doctor, residents, and all the participants. Welcome to our webinar on ototoxicity. Thank you for joining us today. My name is Duhita, and I will be your Master of Ceremony for this event. We have a series of insightful sessions lined up, delivered by esteemed experts in the field of otorhinolaryngology. We hope you find today's discussion enriching and informative. First, we have the head of Indonesian College of Otorhinolaryngology, Head and Neck Surgery, Martani, MD ORL-HNS, Facial Plastic Reconstruction Consultant PhD. For Dr. Ria, the time is yours, Doctor.
Thank you very much, Dr. Duhita, and greetings to all, to distinguished guests, Professor Dr. Haldun Oguz, President of the Union of European Phoniatricians, esteemed international speakers, Professor Antoinette from University of Munster, Dr. Kaukab Rajput from GOSH, Department of Audiological Medicine, London, Professor Rashid Superwata, how are you, Prof? From Indonesian section of German-Indonesian of Medicine Society, respected colleagues and honorable guests. Well, good afternoon to all. Assalamualaikum warahmatullahi wabarakatuh. Welcome to this webinar on ototoxicity organized by the Otorhinolaryngology Department of Cipto Mangunkusumo General Hospital in collaboration with the Union of European Phoniatricians. Today marks an important milestone in our shared mission to advance the understanding and management of ototoxicity. This event will bring experts from across the global and then fostering and valuably exchange the knowledge and experience. We are very privileged to have with us the President of the Union of European Phoniatricians, whose leadership and dedication to the field have been exemplary. Your presence underscore the importance of international cooperation and addressing complex medical challenges. To our distinguished international speakers, we extend our gratitude, our willingness to share our expertise and insight will enhance our collective understanding of ototoxics, its causes and impacts. Toxicity remains the critical area of concern within our field, affecting countless individuals worldwide. As health professionals, it is our responsibility to continue to seek better ways to prevent, diagnose, and treat this condition. I hope this webinar aims to provide a platform for us to endeavor to encourage dialogues and collaboration that will ultimately benefit for our patients. And I'm sure today's discussion will both enlightening and inspiring. Well, let us seize this opportunity to learn from one another, to challenge our assumption and push the boundaries of our knowledge. Thank you again for being today, especially on Sunday, and make this webinar a resounding success. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Ria. The next welcoming speech, we have Dewi Mayangsari, MD ORL-HNS, Oncology Consultant, FICS, Head of ENT Department, Cipto Mangunkusumo General Hospital. For Dr. Maya, please, the time is yours, Doc.
Okay, thank you, Dr. Duhita. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Our Excellencies, Head of Indonesian College of Otorhinolaryngology, Head and Neck Surgery, Dr. Martani, President of Union of European Phoniatricians, and then the Head of Indonesian Section of German-Indonesian Society of Medicine, Professor Rashid, and the Honorable Speaker, Professor Antoinette, as the Honorary President of the Union of European Phoniatricians from the University of Munster, and Dr. Kaukab Rajput from GOSH, Department of Audiological Medicine, London, and also to Head of Indonesian Society of ORL Head and Neck Surgery, Jakarta branch, Dr. Triyuda Erlangga, and also all the panelists, Prof. Yeni and Dr. Rangga, Professor, doctors, and all participants. Thank you very much for being with us this afternoon. So this event is a collaboration event amongst the Department of ENT ORL, University of Indonesia, and Cipto Mangunkusumo General Hospital with European Union of European Phoniatricians, and also with Indonesian College of Head and Neck, and also with Perhati in Indonesian branch, and also supported also by the section of Indonesian section of German-Indonesian Society of Medicine. As we all know, hearing and balance are important senses in life. Many conditions that we frequently encounter in daily practices that perhaps maybe affect the hearing of our medication and treatment received by our patient are ototoxic for internal ear. So, as the head of Head and Neck Department, Faculty of Medicine, Universitas Indonesia, I'm so grateful that we can continuously update our knowledge by having lectures and discussion with well-known speakers in these topics. And I would like also to express my special appreciation for ICTech and also for your help, and also for Dr. Fercha to organize this meeting. Thank you very much for your help and dedication. And I would like also to say hello to our colleagues here, for the doctors, professors, seniors, and the alumni that able to join our session today. It's very nice to see the familiar faces here while learning and having a fruitful discussion. So lastly, I hope all of us can take this opportunity to learn as much as we can from the experts that we have here, and hopefully we can apply today's topic into our daily practice and encourage a new collaboration, research, and so forth for the sake of patient care. So enjoy this webinar. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Mayang, for the welcoming speech. Lastly, we are honored and pleased to welcome the President Union of the European Phoniatricians, Professor Dr. Haldun Oguz, MD. To Professor Dr. Haldun, please, the time is yours, Professor.
Thank you so much. It's a great honor and pleasure for me to be with you today. We have been in contact with our Indonesian colleagues for a period of time, but all of those sessions were really so fruitful for us. It was so enjoyable. And today they have prepared a wonderful webinar. I know that it's wonderful because the preparation steps were so professional. I have a few friends here to personally thank for making this meeting possible for all of us. First one is Professor Ika Dewi Mayangsari, the head of the University of Indonesia, Faculty of Medicine, ENT Department. Professor Tri Yuda Airlangga, Indonesian Society of Otolaryngology and Head and Neck Surgery, Jakarta. Professor Tri Martani, head of Indonesian College of Otorhinolaryngology, Head and Neck Surgery. Of course, my dear friend, colleague, sister, Professor Antoinette Zehnhoff-Dinnesen, the past president of Union of European Phoniatricians. And last but not least, my dear friend, Professor Rashid Soperwata, the Indonesian section of German-Indonesian Society of Medicine's president. This is so happy that you all have initiated this webinar and helped to organize this and make this possible. I know that Indonesia is a very important country. You have nearly 300 million people, and we have lots to learn from you, and we have lots to discuss together. I am sure that this panel will be enjoyable as much as we enjoy. I hope the audience that will follow us will enjoy this as well. And I'm so happy that we have more than 700 registrants already. So let the party begin.
Okay, thank you, Professor. Before we start the first session, maybe we can take a picture. So please, for all the panelists, speaker, and the moderator to turn on the camera. And I will lead and counting from 1, 2, 3. Once again, 1, 2, 3. Okay. Thank you for Professor and Doctor. Now we are going to move on to our first session. There will be two topics discussed in this first session. The topics are platinum-induced ototoxicity and pediatric oncology. And the second is the autoprotective substances and case studies on aminoglycoside ototoxicity. This first session will be moderated by Ika Dewi, Oncology Consultant, FICS. Firstly, I will read the curriculum vitae of Dr. Mayang. Dr. Mayang was graduated and a medical doctor from Faculty of Medicine, University of Indonesia, and she completed the anti-specialist residency program from University of Indonesia, and she being a consultant ORL-HNS oncology from Indonesian College since 2018. And Dr. Mayang pursued a global online fellowship in New York, and then she participated in clinical observation program, Department of Head and Neck Surgery in New York, and clinical observer in Pittsburgh Medical Center. Dr. Mayang is our lecturer and a medical staff in a medical faculty of University of Indonesia, and she is a member of editor in Otorhinolaryngology journal, and until now, Dr. Mayang served as the head of ENT department, Cipto Mangunkusumo General Hospital. For Dr. Mayang, the time is yours, Doctor.
Thank you, Dr. Duhita, for the nice introduction of me. So, we start with our meeting today with the first session about there will be two lectures, and then the first one will be presented by Professor. Can I have the slide? Okay. So, Professor Antoinette is a professor of Phoniatrics and Pedagogy at the Medical Faculty of Philips University Marburg, and of Phoniatrics and Pedagogy in 1990, and then in 1991 is appointed as a professor of Phoniatrics at University and head of clinic of Phoniatrics Pedagogy. And she has a lot of papers and scientific journals that, of course, we cannot mention here one by one. And then from 2007 to 2011, she has been appointed as a president of the German Society of Phoniatrics and Pedagogy. And then from 2017, she has an honorary member German Society of Phoniatrics and Pedagogy, and also I think the others honorary members from the Chess Society, and then also the member of Confederation of German Hearing Screening Center. So yeah, we know that I think so. We very here to give us a presentation about the platinum-induced ototoxicity in pediatric oncological therapy. So I give the time to Prof. Antoinette the presentation in 30 minutes. Please, Prof. Antoinette. Time is yours. We cannot hear your voice, Prof. Antoinette.
Yes, thank you.
Okay, thanks.
Yes. Honorable President, Jenny Bashiruddin, Tri Martani, and Tri Judah Erlanger, and Haldun Oz, and Rajit Supawata, Honorable Chairwomen, Moderators, Ika, Dewi, Mayangsari, distinguished auditory, and dear colleagues and friends. I'm very happy and grateful that I may present my lecture on platinum-induced ototoxicity in pediatric oncological therapy. So this problem, it's very strange here, don't know why. So I will talk about ototoxicity. Ototoxicity is cochleotoxicity, but also vestibular toxicity. And in case of cochleotoxicity, we talk about hearing loss and tinnitus. And when I have the focus pediatric oncology, I only want to talk about platinum compounds. That means about cisplatin and carboplatin. Because, and also I only want to talk about hearing loss, because there are only a few data about tinnitus and vertigo. Yes. It seems that my laptop is not able to load the slides quickly. Take the version from Feruca, my power, because we cannot wait 5.
Okay, sure. Let me do this. Dr. Tommy.
Das geht einfach nicht. Delete die Folie nicht. Ja, das ist wirklich, wirklich blöd.
No, Dr. Tommy, I think it's from me, not the recording one.
Yes, it's very good. Yeah. Yes, please, my PowerPoint presentation. Yes, thank you. So please move, yes, move forward then. I'm extremely sorry, but it's very strange. So cisplatin is a highly effective chemotherapeutic agent in pediatric oncology. It's used in case of osteosarcoma, hepatoblastoma, medulloblastoma, neuroblastoma, and germ cell tumor. Its use is limited by side effects such as ototoxicity, neurotoxicity, nephrotoxicity, and myelosuppression. Next, please. So here you see the structures of the ear, and especially we should look at this stria vascularis. This is very important because cisplatin, or also carboplatin, is accumulated in this structure, in the stria vascularis. And this accumulation is possible for months or even years. So we have to be aware that there may be progressive hearing loss even after the end of the chemotherapy. Next, please. The anti-tumoral effect of cisplatin is to bind DNA, and most important side effects are to generate toxic levels of reactive oxygen species and to induce apoptosis, that means a cell death program. So we observe the death of outer hair cells at first in the base of the cochlea, and then a degeneration of the stria vascularis and spiral ganglion cells. And here you see an animal experiment, the 3 rows of outer hair cells before and then after ototoxic damage by cisplatin. Next, please. Primarily, cisplatin-induced hearing loss manifests with a bilateral sensory neural hearing impairment, beginning in the high frequencies. And when you perform a high-frequency audiometry, you see that there may be already a severe damage at, for example, 12, 14, 16 kilohertz, but in the normal audiogram, you only see a very slight decay. And affected children have difficulty in distinguishing high-frequency consonants, which are important for speech intelligibility, and have a reduced music perception and also a reduced perception of ambient noises. Next slide, please. If the hearing impairment progresses to more speech-relevant frequencies and a higher degree, sincere consequences for a young child's language, psychosocial, emotional, and academic development may result. So you see here different cases with different degrees of hearing loss after cisplatin. Next, please. And I think this is a very important point because many people think that high-frequency hearing impairment does not play such a big role, but it's problematic because it reduces speech perception, especially in noise. And here we have an example of a high-frequency hearing loss after cisplatin. And when you perform a speech audiogram, and I really would recommend to you to do that, if possible, you see that here on the right ear, the child can only discriminate 45% at 50 dB and 65% at 65 dB. But if you add a noise 60 dB loud, then speech discrimination is reduced to 5%. So imagine you are a child sitting at school, there is some noise, you have this high frequency hearing loss, but in the noise you can only discriminate 5% of the speech. Next, please. So in the following inter alia, a selection of studies performed by my former Munster team and cooperation partners is presented. And in blue color. Next, please. We have nothing to declare for these studies. The effect of high-frequency hearing loss on children at school, there is a greater listening fatigue resulting from the increase in listening effort required, a reduced attention span, a poorer school performance, and we have found in our study a reduction of the health-related quality of life by hearing loss and by tinnitus. Next, please. The reported incidence of cisplatin-related hearing loss in childhood ranges from 45 to 83.3%, respectively from 42.62 to 55.82%. And you will ask me, why are there these differences concerning the incidence data? And we try to explain this by in several studies and heterogeneous study populations and study protocols, but also sometimes hearing loss is defined in another manner, and there are different audiological classifications and also different measurement times. So some measure hearing loss during chemotherapy or at the end of chemotherapy, but you should also measure it in form of a post-therapeutic monitoring protocol because of the possibility of progressive hearing loss after end of the chemotherapy. So next, please. What are the risk factors of cisplatin-induced hearing loss? So pre-existing hearing impairment, very young age of children, high cumulative dose, additional cranial irradiation, also surgery involving the ear or the auditory nerve, a combination of cisplatin with carboplatin or other ototoxic medication like aminoglycosides or loop diuretics, and a total duration of concomitantly administered antibiotics more than 30 days. And Kaukap and myself, we are discussing if vincristine really plays a role, but also the renal function is important because the excretion of platinum products is via the kidney. So a higher serum creatinine value at diagnosis may also be a risk factor. Next slide, please. We made some studies on risk factors, so we found out that short-time infusion is a risk. And if you do a co-medication by furosemide, it's also a risk. And then we work together with our radiotherapist when there is additional cranial irradiation. And we found out that tomotherapy, that means that the machine is rotating around the patient similar to the CT scanner, that this is combined with lower risk of hearing loss. And we have found, and I think this is also a very important point, that the audiological outcomes were better for patients who received cranial radiotherapy after platinum chemotherapy than before. So if you start with a cranial radiotherapy, there is a hyperemia, and then more toxic cisplatin goes via the vessels to the inner ear. So you have a toxic effect of cisplatin. And so if possible, it would be better at first to do the platinum therapy and then to continue with the cranial radiotherapy. And then we have studied the tomotherapy and different positions of the patients, because it is important to know about the pathway of the X-rays and to know about the cochlear dose of the X-rays. And we found out that there is a lower risk of hearing aid indication when tomotherapy and supine positioning of the patient were performed in medulloblastoma patients. Next slide, please. Then we were wondering, because we saw children who had severe hearing loss very quickly after relatively low doses of cisplatin. And on the other hand, we saw children with normal hearing after high doses of cisplatin. So we were wondering if there is a genetic background, possibly similar to the genetic background of aminoglycoside toxicity. You know that there is a variant in the mitochondrial genome 1555A2G, which is something like a genetic screening already, which can be used like a genetic screening to find patients who are at a high risk to develop hearing loss after aminoglycosides. So we hope to find something similar for platinum products, and we worked on genetic variants in influx and detoxification, and we found a critical variants concerning glutathione S transferase, megalin receptor, and organic cation transporter 2. And I'm very happy that these ideas are still followed recently by other colleagues. So they study genotypes encoding cisplatin efflux, DNA repair, and apoptosis-related proteins. And one team found the null genotype from GSTT1 as to be critical, as we have already found many years ago in this glutathione S transferase. So next slide, please. Our aim is to find the patients who are at risk to have a severe hearing loss at the end of chemotherapy at a very early stage during chemotherapy. So we developed the audiological Munster classification of high-frequency hearing loss with multi-level discrimination within the hearing loss categories and considering tinnitus and minimal hearing losses. So you see that I have marked this 2B here. 2B is the value which is then as a significant hearing loss. You can see it as a significant hearing loss. And Munster 2B and more means clinically significant hearing loss. Less than 2B means not significant clinical hearing loss. And this classification is based on the Brock classification, and our classification is evaluated by other independent groups as the most sensitive audiological classification because we consider minimal hearing losses. I showed to you that in the normal audiogram there may only be a very slight decay, but when you do a high frequency audiometry you see much more severe decays. And we consider also tinnitus. Next slide, please. Within a EU study project, the PenCare Life project, we have done more studies, and we did this with the goal to reduce long-term sequelae of tumor therapy for survivors of childhood and adolescence cancer by identifying clinical and genetic risk factors. And the heads were Dr. Julian Byrne from Ireland and docent Peter Karch from Mainz in Germany. We have got data from 17 institutions in Austria, Czech Republic, Denmark, Germany, Italy, the Netherlands and Switzerland, with Munster as European Audiological Reference Center. Next slide, please. So here is our group, our study group, and next slide, please. Some results. We had 10,320 audiograms from 2,696 patients. 55% were male. The mean age at diagnosis was 9.9 years. And most common tumors were bone, brain, and liver tumor, tissue sarcoma, and neuroblastoma. Next slide, please. And we found a clinically relevant hearing loss in 48%, and when you read the more recent literature, then this value from about 50% clinically relevant hearing loss is okay. Next slide, please. Then we studied risk factors. Sex is no risk factor, but an age less than 5 years is a very big risk factor. Also, additional cranial irradiation is a risk factor and a higher cumulative cisplatin dose. Next, please. Compared with children more than 15 years of age, young children under 5 years were more likely to exhibit a platinum-associated hearing loss. Patients who had received a cumulative cisplatin dose of more than 450 milligram per square meter had odds increased by a factor of 5.0 to exhibit platinum-associated clinically relevant hearing loss. And radiation versus no radiation also had an odds ratio of 3.53. Next slide, please. So then we also did some genetic studies in the PCL program. And at first we have studied 11 candidate genes and found variants from ACYP2 and from SLC22A2. And the first gene is hinting to muscle metabolism, and the second one is an organic cation transporter gene, which is important for detoxification. So there is some evidence, but we suppose a polygenic model with multiple interacting genes of the cisplatin pathway that might be meaningful. Next, please. Then we did a genome-wide association study in 390 cisplatin-treated children, which were not cranially irradiated. And we found a genetic variant in TCERG1L. and this is associated with cells response. And when you modulate its expression in culture, you have an altered cellular response. Next, please. Here I have collected the most recent studies on genetic variants which are supposed to be associated with cisplatin-induced ototoxicity. So we have genetic variants concerning muscle metabolism or excretion of drugs, metabolizing drugs to deafness and to degenerative neurological diseases, to signal transduction and to regulators who regulate immune responses to inflammation or trauma. So it's very diverse, and it's very sad, but up to now, we do not have a genetic screening possibility similar to the genetic screening concerning aminoglycosid ototoxicity. Because there are conflicting results, we could not find up to now such a genetic marker for children to be at a higher risk to develop hearing loss. Next, please. Here is a study together with Czech colleagues, and we found that the older the child is at beginning of therapy, it's better for the academic achievement. Next, please. And we have here the slide with the Swiss colleagues, 270 childhood cancer survivors from the SWIFT childhood cancer registry, and 3 or 4 from these children had some degree of hearing loss. And we found the known risk factors, but in addition, hematopoietic stem cell transplantation. And what we have learned is that it is really necessary to monitor the hearing of these children, especially when they are young, when there is a high cumulative cisplatin dose and an additional cranioradiotherapy. And please be aware of the possibility of a progressive hearing loss even after end of chemotherapy. Next, please. So we did some guidelines for monitoring, and I'm a member of the International Late Effects of Childhood Cancer Guideline Harmonization Group, and we could publish these guidelines in Lancet Oncology. And next, please. This is our group. Next, please. Yes, and we also did some recommendations which kind of audiological testing should be done, and we could publish this in JAMA Oncology. Next, please. And I worked also for the German guideline in this matter, late effects. Yes, next, please. And shortly about carboplatin. In childhood, it's used concerning retinoblastoma, osteosarcoma, and neuroblastoma. One side effect is ototoxicity, and we have, in comparison to cisplatin, a relatively low incidence of ototoxicity, but in combination with cisplatin or other ototoxic drugs, and also in combination with cranial irradiation, and when you give a higher dose of carboplatin, or in case of osmotic opening of the blood-brain barrier, it's also ototoxic. Next, please. Otoprotection is the topic from Kauka. And next, please. So we have still something to do. We have to implement monitoring standards. That's very important. And we have to clarify the pathogenetic basis of ototoxicity of platinum compounds, further to define and consider clinical risk factors, and still to develop pharmacogenomic genomic markers to identify high-risk patients, and to continue to develop, to evaluate, and to implement otoprotective strategies without reducing efficacy of chemotherapy. And please, I've come to the end of my lecture. Yes, next, please. So here are the teams. The team from Marie van den Heuvel-Eijbrink in Utrecht, the Netherlands. Then my former Munster team and the PenCare Live teams. And from Munster also Giuliano Charimboli from Experimental Nephrology and Sergio Scobialla from Clinic for Radiotherapy, Radio-Oncology, Claudia Landfas-Kaminski from the Working Group Clinical Pharmacology, and from Czech Republic, Jamila Kruziova, and from Switzerland, Claudia Kühni. And my very last slide. So I'm very sorry for the technical problems. Really, really, I'm very, very sorry. And I thank you for your attention.
Yeah, thank you very much, Prof. Antoinette, for the wonderful presentation of you. Although we have a little technical problem, but it's still in time. Yeah, and now I think we can move to the second presentation. Yeah, and Dr. Kaukap Rajput will be the speaker for the next one. Dr. Kaukap was a Bachelor of Medicine and Bachelor of Surgery from Pakistan, and she got a license of the Royal College of Physicians and Surgeons in Edinburgh and Glasgow, and also the Fellow of the Royal College of Surgeons from the Royal National Throat, Nose and Ear Hospital, and the Consultant and Master of Science in Audiological Medicine, the Royal College of Physicians, London, 1999. And she's not the Consultant Audiological Medicine in Great Ormond Hospital, and then the head of GOSH Cochlear Implant Department, and the lead of etiology investigation groups of good practice guidelines for offering cochlear implant for children with auditory neuropathy spectrum disorder. And the top solicitors as a medical legal expert in audio vestibular medicine. So, Dr. Kaukap, you have 30 minutes to present your presentation. Please, time is yours.
Thank you. Let me just see. I have emailed my slides in case I have the same technical issues that Antoinette had. So good morning from London and welcome. And let me just see how you say this in Indonesian. Selamat datang, right?
Yeah, that's right.
It's my very feeble attempt to say welcome in Indonesian language. And thank you very much to all the panelists and all the people who thought of me, and especially Antoinette, for introducing me to your group. So I'm just hoping that I will not have the technical issues that Antoinette had, but you have the slides. Oh, no, I don't. Thank you so much. Now, I just want to lay the hearing loss. So at the moment in the world, there are 1.5 billion people who have a hearing loss. And this is likely to increase to 2.5 billion by 2030. Now, we all know that the incidence of newborn hearing loss is 1 in 1,000. But we have done some studies in London, and coming from an ethnic background myself, I had a special interest in ethnicity and hearing loss. And certainly in London, the ethnic population, the incidence is 2.5 in 1,000, which is more than double what we see in the Caucasian local population. Now, it is been suspected, or it's been proposed, that there are around 1 billion people between the age of 12 and 35 years who are at risk of hearing loss from recreational exposure to loud noises. We must remember these kids and teenagers are walking around with their headphones and listening to loud music. So overall, according to WHO report, the cost of unaddressed hearing loss globally is $980 billion. So they have issued what they call as hearing care package. And you can see that the hearing care package not only includes hearing screening and intervention, but prevention of ear diseases and prevention of hearing loss. Then, of course, access to technology, rehabilitation services, improved communication, as well as identification and engaging these people to use some form of amplification to improve their quality of life. So I am going to do a quick presentation on etiology of severe to profound sensory neural hearing loss, which was published recently, last month, in American Academic Journal. And then the implication or the impact of what Antoinette talked about, the genetics of hearing loss. And what I want to emphasize is that ototoxicity is a preventable cause of hearing loss. And if we can somehow protect these children and people who are undergoing chemotherapy or having treatment for cancers, we can stop their hearing deteriorating. I think that would be an excellent outcome. So I'm going to talk about the success story of Bedmark, and then I'm going to touch upon aminoglycoside, which is quite a bugbear for me, at least in my department. So the publication that was published recently, we looked at children who were undergoing cochlear implant assessment, because I lead the cochlear implant program in Great Ormond Street Hospital. And from 2013 to 2022, we looked at a group of patients, a cohort of patients, and we had 476 children who were undergoing cochlear implant assessment, and we carried out deafness panel testing. Up until then, 2017, we were only doing Connexin 26 to identify hearing loss. And what we found was that more than almost half, or almost 44%, had some form of genetic cause of hearing loss. So that really was quite surprising and interesting. And around less than half of our cases had hearing loss due to non-genetic causes. And when we looked at the acquired causes, what I noticed was that previously, when I started in 1999, the commonest cause of acquired hearing loss was meningitis. But in our current cohort, the commonest cause of acquired hearing loss is ototoxicity. So because we test these children's hearing before they undergo treatment and then after, we realize that it is the ototoxicity, which is now the commonest cause within our cohort of children with severe to profound hearing loss. So if you look at the hearing loss and its impact on speech, particularly in English language, you can see that the hearing, as the treatment progresses and the toxicity progresses, a significant chunk of identification or discrimination ability is lost in children undergoing chemotherapy. So this is an example, and you have seen what Antoinette showed. So this is the case where the pre-treatment, the hearing was perfectly normal. These are young children, so going over beyond 8 kHz is difficult, but we do extended high frequencies. And this is the outcome after. So you can see, if we look at the frequency distribution in different languages, and I'm sorry I don't have Indonesian language here, but you would note that the English language is most affected. So all the English-speaking countries, including where I am, there is a significant impact in the discrimination ability of the child. And Antoinette has already identified they are young children. They lose their ability to discriminate high-frequency sounds. They lose their ability to concentrate when there's a lot of background noise. It really has, and this is their stage of learning. So this has a serious impact on their ability to function as a normal, healthy child in school when they should be getting education. So in 2000, a year after I started working in Great Ormond Street, we set up a dedicated clinic for children who were undergoing chemotherapy or who were at risk of ototoxicity. Now, we are not talking about just the children who receive cisplatin or carboplatin. We are also talking about children who have blood cancers, such as leukemias or cytopenias or pancytopenias, and who are undergoing, as the advances are happening, are undergoing bone marrow transplants, undergoing stem cell transplants, and now they are undergoing CAR T cell transplants. So there is a lot of progress happening in life-saving procedures for children who would otherwise have had life-limiting condition. But as the treatments are progressing, unfortunately, the side effects are becoming more and more apparent and having an impact on quality of life of these children. So we set up a hearing test protocol within GOSH, Great Ormond Street Hospital, and we have been using, so we don't use any, we prefer, and so the protocol is that we use objective and subjective hearing loss depending on the age of the child. And as I mentioned, we use Brock ototoxicity because Brock and Bellman were working in Great Ormond Street Hospital. And they published a study in 1998, so a long time ago, while I was a trainee. So just a list of ototoxic medication that the children may be exposed to. And you can see that not only aminoglycosides are a biggest offender, but there are other medications such as erythromycin, particularly if given intravenously. And there are vancomycin as well, which can lead to hearing loss. Loop diuretics, Antoinette has already mentioned. We don't use quinine, but we tend to forget that quinine, which is used quite a lot in Africa, for example, can lead to hearing loss. And it can lead to not only cochlear toxicity, but vestibular toxicity, some of these medications. So we use, at the moment, we were using Brock ototoxicity grading scale. But after 2010, when there was a meeting in Boston, a group of oncologists and audiovestibular physicians and ENTs got together in US, in Boston, Massachusetts, and developed what they call is PSYOP grading. And now a lot of studies are looking at PSYOP grading. So PSYOP grading a little bit complex because it uses 20 dB as a cutoff, but then grade up to grade 3 ototoxicity, but at grade 4, they use 40 dB at 2 kHz as the grade 4 ototoxicity. So because these are all important speech frequencies, I guess using 2 kHz is an important frequency. So I'm not going to spend much time on this, but the study that I'm about to present, but before I go to that, Antoinette mentioned the risk assessments. So we actually have developed what we call is the GOSH ototoxicity risk score, which we have not published because we haven't got time to do that, but certainly it's something that we can work on. So we look at, whenever we assess, and myself and my team would do a risk assessment. So we would look at children's history. Birth history is very important as well. So if they have an already underlying sensory neural hearing loss, which may be due to any other cause, or it may be due to previous chemotherapy. Any history of intracranial infection, don't forget, children who have had brain tumors, they often have surgery carried out, possibly before the chemotherapy starts, and they are at risk of developing infections, intracranial infections, encephalopathies, and sometimes meningitis, sometimes cranial abscesses. Children may also have syndromes. For example, children who are coming for bone marrow transplant may have Noonan syndrome. They may have Down syndrome. Down syndrome is known to have Philadelphia chromosome, and they can have leukemia. So therefore, they may be eventually candidate for bone marrow transplant. So, but another important factor is family history of hearing loss. Among the Asian families, particularly coming from the same ethnic background as myself, or Bangladesh, or Arab countries, there are cousin marriages. I consider that to be a risk factor. But there may be other underlying and, predisposing factors which we may not have identified. But certainly previous history of exposure to ototoxic medication, especially in bone marrow transplant patient or immune suppressed patients, they may have had even short courses of amikacin or gentamicin that predisposes them. Because as mentioned, and I will show you a paper, that these medications do not clear the ear. They sit in the stria vascularis. The lesser intermediate risk is children who are premature, children who have had exposure to jaundice in the neonatal period, children who have had history of recurrent ear infections, and history of exposure to loud noises. Now, we tend to forget that there is a lot of noise around these kids. And in old days, they used to be put in a skaboo or niku, which had very loud machines around. And low risk is none of these risk factors. So I just want to mention the impact of ototoxicity induced hearing loss on quality of life of children. So among the survivors, so there is a study from St. Jude's Hospital in US, where they looked at the quality of life of adults who had childhood cancer. And this was a non-CNS cancer because the brain tumors have different impact on child's quality of life and their emotional well-being. So they looked at the people who survived childhood cancer, which was blood and solid tumors. And they found that the 39% of these people were not living independently, 45% never married, never had, and again, 34% did not go to school or did not come out with a qualification and unemployed. But what was really striking was that of the people who had relatively poor quality of life, people who had hearing loss secondary to the ototoxicity were twice as likely to have these problems. So perhaps almost 70% or 60 to 70% of these people had some degree of hearing loss secondary to ototoxicity. And therefore, so we did a study in Great Ormond Street Hospital where we sent a quality of life which was specific for children or young people who have hearing loss secondary to ototoxicity. And we had a mixed group. We had people with solid tumors and were exposed to cis and carboplatin. We had people who were undergoing bone marrow transplant. And so we looked at 4 domains: communication and independence, emotional well-being, peer comparison, and acceptance for themselves with the hearing loss. And what we found that in all domains, children who had normal hearing at the end of their treatment, their cancer treatment, had relatively better scores and higher scores, especially when it came to emotional well-being and acceptance and peer comparisons. And what I found, and I'm sure Antoinette will agree, that one of the things which is very important to these children is when you offer them hearing aids and their resistance to using the hearing aids. They don't want to be different from their peers. And somehow they feel if they wear the hearing aids, they will not be accepted by their peer. And it is so important that we keep all this in mind when we are looking after these children who have had treatment and who have got a, alhamdulillah, good life expectancy, but has a hearing loss and has to wear either a hearing aid or a cochlear implant. And as Antoinette already mentioned, there was a study by Bergoli and her colleagues, by Bergoli and Lisa Cunningham from US. And what they found was that the cisplatin stays in the cochlea indefinitely. It does not clear. It's there. So even 3 years later, or 4 years later, say a child has a head injury or is exposed to loud bang or loud sounds, the hearing loss can come, and hearing loss does not, they are not protected from hearing loss due to due to cisplatin sitting there. So in 2005, we started work, and in 2007, we recruited the first patient for ototoxicity protective study. So my colleague, Peppy Brock, who has now retired, she led this research, and we looked at sodium thiosulfate as an otoprotective agent. Now, we had the study group was the group which had cisplatin and sodium thiosulfate, and the control group only had cisplatin. So they had infusion of cisplatin over 6 hours, then a 6 hours gap, and then 15 minutes infusion of sodium thiosulfate. And that was the cycle. These children were randomized and controlled, and our pharmacy, Great Ormond Street pharmacist, randomly allocated them. So I had to study all the audiograms. So there were large number of centers who participated in these. They were people from children from 12 countries. And the results showed that, I'm trying to get rid of this. I don't know what to do about it. Let me just move it so that you can see the graph. So the outcome of that study, which was published in New English Journal of Medicine in 2018, showed that the control group, which did not have any otoprotection, the 63%, and Antoinette mentioned up to 83% can have a hearing loss. So in our cohort, in the cohort that we were looking, 63% of control group had hearing loss, significant hearing loss, grade 1 or worse. And in the study group, this was reduced to 32.7. So roughly 33%, but their degree of hearing loss was less as well. And therefore, the study concluded that addition of sodium thiosulfate administered as recommended. And one thing I need to mention as well, that these were all hepatoblastoma patients, so that there was only monochemotherapy. Only cisplatin was given, and other chemotherapy agents were not given to these children. And therefore, the conclusion was that it reduces by just almost half the risk of ototoxicity. And another study, and I'm not going to go into too much detail, it's called the COG study, which was done by America. So started after UK study, but after the European study, or what we started in GOSH, but it was completed before us. So they did it over a shorter period of time, and their outcomes in terms of otoprotection was similar. So 31 out of the 55 cases who were control group, who only received cisplatin, developed hearing loss, and in the study group, 28% developed hearing loss. So the conclusion was that sodium thiosulfate protects the cochlea, perhaps does not completely obliterate the risk of hearing loss, but it certainly reduces by 50% or less. And this was given FDA approval on 20th of September 2022, and it's now commercially available. This is where the name PEDMARK came from. As I've mentioned, all the people who participated in the study, and these are the people who actually played an active role. Now, I have to say that PEDMARK is now available in US. If anyone in Indonesia or Thailand wishes to access this medication, then they have to contact the CEO of Fennec Pharma, which developed this medication. Okay, so coming to the case reports, and I know I'm running out of time very quickly. So this is an example. We talked about vincristine and carboplatin. Does the combination of these two medications lead to hearing loss? So here's a child who was 12 years old. This is a discussion that happened between me and Antoinette, so I thought I'll present this. So this is a boy who presented with medulloblastoma, had radiotherapy and combination chemotherapy, which consisted of vincristine and carboplatin. No cisplatin was given to him. So the pre-chemotherapy audiogram is done in 2022. And this is the post-chemotherapy. Now you can see that there is an asymmetry between the two ears, the right ear and the left ear. Left ear is worse. And as Antoinette mentioned, the radiotherapy is a risk factor and the field of radiotherapy is a risk factor. Our children are also undergoing proton beam therapy for intracranial tumors. So, and I feel, and I am observing, I'm learning, I don't know yet, but proton beam therapy possibly is more ototoxic. But this is one case. This is another case. This is a child who presented to us at the age of 9 years, had chemotherapy, which was cyclophosphamide, so not ototoxic therapy for lymphoblastic leukemia, acute type B cell lymphoblastic leukemia. She had cyclophosphamide. She then relapsed and needed a unrelated, they call it MUD, matched unrelated donor, bone marrow transplant, and pre-BMT in November 2019, her hearing was perfectly normal. And we tested her in June this year. So this is fresh off and this is what her hearing looks like. You can see she has developed a significant hearing loss. She's virtually hovering around cochlear implant criteria as stands in UK. Basically, this is a list of all the ototoxic medications and the agents that are being investigated. Now, I'm not saying PEDMARK or sodium thiosulfate is an ideal otoprotective agent. What I am saying is more research needs to be done. For aminoglycosides now, we are looking at acetylcysteine and acetylcysteine protection. We use this in our patients where I have classed them as high risk. Now, what we have not done, and I don't know how easy it's going to be for me to do it, but I think younger people should take this forward, is to look at the role of an acetylcysteine in protecting hearing loss from aminoglycosides. But it has to be randomized controlled trial. I'm not going to be around for another 10 years, so I'm going to pass the baton on to the younger people. So thank you for listening. And I have somewhere stored how to say thank you in Indonesia. Terima kasih.
Yeah. Thank you very much, Dr. Kokap, for the wonderful presentation. So yeah, so we have heard from Prof. Antoinette and also Prof. Dr. Kokap that the ototoxicity in children can impact the hearing. It will come to the sensorineural hearing impairment, and it will be given an impact to young children for the language, psychosocial, emotional, and also the academic life. But we also hear that the life, but toxicity is preventable. Maybe with the agent like a sodium thiosulfate, and the other one is an acetylcysteine, which is still undergoing investigation. Yeah, I think we have a lot of questions, I think, because we know that here in Indonesia, we have a case of pediatric nasopharyngeal carcinoma which is the
Yes.
treatment is using a cisplatin base beside the radiotherapy as a primary treatment. So I think maybe we can also have can have research for these cases. Yeah.
Absolutely.
Okay. Yeah. So I think I will read some questions that have been asked from the audience. The first one is from Dr. Moderator. How is the treatment for hearing loss because of the chemotherapy or tuberculosis agent? Yeah. Because of this treatment. Okay, maybe from the Prof. Antoinette first.
Yes. First thing, you reduce the doses or to change the drug. This is also a strategy. So in case of cisplatin therapy, you can try to reduce it. You can change to carboplatin, which is less ototoxic. This could be possibilities, but of course, this always has to be discussed with the pediatric oncologist. Life is more important than hearing. So our primary goal is that the child may survive. And so we can only do recommendations. So we are very happy that we have these otoprotective substance now, this sodium thiosulfate, which is also accepted meanwhile by the European Medicines Agency, the EMA, and it is called PET-MARXI, and it's allowed in Europe for patients old 1 month to less than 18 years with a localized non-metastatic solid tumor. Very, very important, as already Kaukab mentioned, is also that there should noise be avoided. So that such a child does not wear Walkman or something like that, because noise is not a good idea in that situation.
Okay, thank you, Prof. Antoinette.
So,
yes,
so for tuberculosis, in at least in the Western countries, they do not use aminoglycosides. They use rifampicin. Certainly in our hospital, we would the first line of treatment would be rifampicin rather than aminoglycosides. The aminoglycosides are only used when there is a resistant TB bacillus is resistant to rifampicin. And then we would carefully monitor the hearing. Unfortunately, if as Antoinette mentioned, it's survival or losing the hearing, then there is, and acetylcysteine, there isn't any evidence that it can protect against streptomycin, for example, or gentamicin. But we have some weak evidence, but not properly researched against amikacin. So one can try because it does not interfere with the function of the antibiotics, for example. It does not interfere with the efficacy of the drug. So it's a completely different kind of mode of action. So,
Okay.
so I think where possible, avoid using streptomycin or gentamicin. Try rifampicin, which is not ototoxic, or is
Okay.
not as ototoxic.
Yeah. Thank you, Prof. Akap, and also Professor Antoinette. So in this case, we have to reduce the dose and change the medication, change the drug if it is possible, and avoid the drugs that consist of aminoglycoside. Yeah.
Yeah.
Thank you. So Dr. Amade, I think your question is already answered. So the question from Dr. Ronnie Swento. How about the other platinum drug, which the name is oxaliplatin? Yeah. Do you have any experience with this medication, oxaliplatin? No.
May I answer? Okay.
Yes,
I
please, Prof.
do not know data from oxaliplatin. I'm sorry. I do not know.
Yeah.
I think it is not so effective as a cancer drug, and was not used in our patients.
Yeah. I can add also some comment about this. I think this medication is also not very common in our country. If we want to use the platinum base, so we use the cisplatin, very widely used. So and what I know is this regimen is used for GI tract malignancy. That's what I saw. Yeah, I don't have also experience for these drugs. Okay, so the other one is how about the SOP or the protocol of monitoring the case with ototoxicity? It is mentioned that we have to check it during or at diagnosis and during therapy and then post treatment. How long is we have to follow up with the OIA maybe or audiometry after the treatment? How frequent is it and until when? Thank you. Maybe Prof. Antoinette, or you can answer first.
Yes, we do a basic audiogram. I think that is very important to have this basis. And then we are used to do audiometry before a cycle. So when you do audiometry after the cycle, we had the experience that the child may be very ill or that there is some temporary hearing impairment or something like that. So we are used to do it before the next cycle. Then at the end of chemotherapy, and I always propose to do it then in the first year, all 3 months, and afterwards all 6 months, and then yearly. And yeah, especially when there has also been a cranial irradiation, because there also a progression of hearing loss may be observed. But I would like to hear also the opinion of Kauka, please.
Okay. Yes, please, Dr. Kauka.
So thank you. So we are the regional center for childhood cancer. So we have huge caseload. So we cover the whole of sort of, London, and London is a big city, and 50 miles, so around that. So we get a lot of children. So we do monitor. So I see them, or my team, my juniors, my colleagues will see them before they start the treatment. then they have the cycle depending on, some of the children are undergoing cycle, having treatment, which is for 18 months long. And so they will have a hearing test depending on the protocols. So for example, there are certain protocols that give me a heart sync, for example, Kojak, rapid Kojak. There used to be another very horrible combination where children used to get cisplatin and carboplatin. So we would do the hearing test in between, when, as Antoinette said, before they take the next course, because they're much better, they're out of hospital. But they do freak out, especially the 18 months, 2 years old are very difficult to test. So we try and do the hearing test. We try and do behavior hearing test. We try and do otoacoustic emission. So we use combination of an objective and subjective test. And there have been times we may do auditory brainstem responses as well, depending on the age and ability to give them sedation and do the AVRs. We try and do it in between every course, in between the treatment. So if they're on cisplatin or a combination treatment, which is high, every time they receive cis, because there are certain protocols where they don't receive platinum every cycle, they receive it in, cyclophosphamide or etoposide for a cycle. And then, so every time they get cisplatin, we would try and do a hearing test before they go for the next platinum-based medication. Then at the end of the treatment, and if the hearing is normal, unlike Antoinette, we see them 6 monthly, but we do engage their local audiology, pediatric audiology team. So we get them to see the local audiology team as well, because we really get like 150 children a year, new cases coming through. And we just don't have the capacity. So we are also working with the local audiology team, pediatric audiology teams, to take over in between monitoring. And if the child is old enough and say, I can hear buzzing, then we need to get them tested. Or the parents notice. And then of course, the complicating factor is the glue ear. So that can also lead to hearing loss, what we call is otitis media with diffusion. So then it becomes important, because we just want to make sure that the children's hearing is ident. If there is a loss, whatever, sometimes secondary to middle ear effusion, it is optimized and they're monitored. So yes, so we do 6 monthly and then once a year.
Okay. Thank you very much, Dr. Koka. Yeah. So we can monitor the hearing test every 6 months. Okay. The committee had already remind me about the time. Unfortunately, there are many questions that cannot be answered this time, but I think we can send this question to Dr. Kokap and also Professor Antoinette, and it will be answered as soon with maybe the email, I think. Yeah. Okay. So thank you very much, Prof. Antoinette, and also Dr. Kokap, for the nice presentation and also the wonderful discussion. I think we have a lot of knowledge here. We have a lot of many things that we have. We should do here in Indonesia. We can also make a new research here about the otoprotective agent, I think. Yeah, because we also have many patients with the ototoxicity.
Yeah.
Okay. Thank you very much.
Can I ask you a question?
Yeah. Yes.
Do you have, sorry to ask this, it's quite a sensitive question. Do you also, in Indonesia, like my country, originally I'm from Pakistan, do you also have cousin marriages?
Cousin marriages, not really widely here, but in a small part of area, I think yes. Yeah.
Okay. Thank you.
Yeah, that's one of the risk factor for ototoxicity, right?
That's my observation, that it is a risk factor, because it predisposes, if there is a genetic mutation and genetic, then the chances are higher. So that's my observation within the community in London.
Okay, thank you very much. Thanks again, Professor Antoinette and Dr. Kokap. So I have to finish our session this time. So I will give the time to Master of Ceremony. Thank you very much.
Thank you.
Thank you, Dr. Mayang, Professor Antoinette, and Dr. Kaukap. The first session discussion, very interesting, provided a lot of knowledge and very highly informative. We now open the floor for the panel discussions. We have 4 panelists with us for today's discussion. Our panelists, the floor for the panel discussions. We have 4 panelists with us for today's discussion. Our panelists for the session are Professor Antoinette, Dr. Kaukap Rajput, Professor Jini Basrudin, and Dr. Juju Erlangga. Our panel discussion session today will be moderated by Professor Dr. Haldun Oguz and co-moderated by Dr. Angga. The first, I will read the CV of Professor Haldun. Professor Haldun graduated a medical doctor from Hacettepe University, Ankara, Turkey, and he completed a residency on Otorhinolaryngologist, Ministry of Health, Ankara Training and Research Hospital. Then he pursued a fellowship at Harvard University Medical School, Institute of Laryngology and Voice Restoration, and he became a professor of Otorhinolaryngologist. He is the president Union of European Phoniatricians and Professional Voice Society in Turkey, and also he is a lecturer in Department of Otorhinolaryngology, Faculty of Medicine, Lokman Hekim University, Ankara, Turkey. And he is the director of Phoniatrics and Audiology Clinic in Ankara, Turkey. Next slide. This is the curriculum vitae of our co-moderator. Dr. Angga graduated a medical doctor from University of Indonesia in 2010, and he completed the anti-specialist residency program from University of Indonesia, and he underwent courses and training in Hong Kong Adventist Oncology Services, in and SGH ENT course for cochlear implant surgery in Singapore, and TSCSI lateral scalp surgery in Dubai. And Dr. Angga is our lecturer and the medical staff, Otorhinolaryngology Head and Neck Surgery Otology Subdivision in Cipto, Mangunkusumo General Hospital. I will now hand over to, this is the curriculum vitae of Professor Jini Basrudin. She graduated a medical doctor from University of Indonesia, and she completed the Otorhinolaryngologist from University of Indonesia, and now she is a neuro-otology consultant, and she became a professor of Otorhinolaryngologist from University of Indonesia. And now she's the medical staff of the Neuro-Otology Subdivision, ORL-HNS Department, Faculty of Medicine, University of Indonesia, and she is the chairman of Petri Perhati KL from 2019 until 2022. Okay, I will now hand over to Professor Dr. Haldun and Dr. Angga to lead the panel discussion. Professor Haldun and Dr. Angga, the time is yours.
Thank you very much for the presentation. And I'm so happy that we will be moderating this panel with my young colleague, Dr. Ranga Rayandia Salih. If I am spelling wrong, I am so sorry, Salih. Salih is a so familiar name for me. And as we have already listened perfect presentations from 2 colleagues, dear Kokap and dear Antoinette, you know both of them. We will have 2 other panelists here. As mentioned, Professor Jini Basrudin and Professor Triyuda Erlangga. My friend Ranga prepared some cases for us in the panel to discuss. So Ranga, the stage is yours. I will be here to help you.
Okay, thank you, Prof. Haldun. So I'm going to, so we have several cases this afternoon. We will see how many cases can we cover due to the time. But then, can I have the comment? Can I please the committee to show the slides, please? So
Ranga, before you begin, I will just make a comment, a request to all the audience. This is the open discussion part of the meeting. So please feel free to send your questions to the Q&A part. I know that we have already some questions that are not answered yet. So we can discuss them among the patients, or we can discuss them as well. Thank you, Ranga, and I'm sorry.
Okay, thank you, Prof. Haldun. So I'm going to start with the first case slide. So this one, the clue of the case is about the relationship between ototoxicity and systemic antibiotic drugs. So this first case is a female, 4 months old. So it's a 4-month-old baby. The patient is referred to the hospital for a hearing evaluation after anti-tuberculosis drug therapy. Slide. So this is the history of the patient. The patient was diagnosed with pulmonary tuberculosis and also given anti-tuberculosis treatment for 2 months with the regimen of rifampicin, isoniazid, and also pyrazinamide. But then she experienced a drug-induced liver injury. So the treatment regimen will be changed. And the plan is for the initiation of a drug-resistant tuberculosis regimen, which we know that it has a risk of ototoxicity. The plan for the treatment is levofloxacin, bedaquiline, linezolid, clofazimine, and cycloserine. Right? So in this kind of patient with the planning for giving the ototoxic anti-tuberculosis drugs, so what examination should we do? So I'm going to pause here and then I'll ask comment from the panelists first, maybe Prof. Haldun.
I want to combine this with a question from the Q&A part. One of our friends, colleagues also asked about how to monitor ototoxicity in children. What kind of an audiometry method? Is screening enough? Or is just screening the air conduction enough? Even in some frequencies, let's say the speech frequencies. So if you combine this question for a patient like this that will receive possible ototoxic medication for treatment, how should we begin? Any comments from the panel?
Yes.
Yes,
Prof. Haldun, thank you for the time for me. Yes, maybe we have firstly we have to check the monitoring, that you have to know the baseline before the therapy, if we can. Sometime and then when the base after the ototoxic begin, and also we have to know about the prognostic factor for the baby for 4-month-olds. So is there any ototoxic, because there is a lot of medication that can give to the baby with the 4-month-old. And sometimes we have to know about how to monitoring the ototoxic. So for the baby 4 months old, maybe we have to check the audiometrics, such as brain evoked response audiometry, ABR, or sometimes we can also check the ORA, ototoxic emission, to check maybe there is some risk factor in the cochlea. Sometimes the first line ototoxics begin from the cochlea. And then also we have to check the progressive test. The progressive from the ototoxic to lead the hearing loss case, we have to check regularly. Maybe some cases we have to check, especially for the children with 4-month-olds. Thank you, Prof. Haldun.
Thank you. Thank you very much. Actually, what I have recalled is that we should have a baseline test. Of course, besides making a Doro, ENT, and head and neck exam, to be able to know what are the other factors that may be related with the prognosis, not just tuberculosis, not just the treatment, but the other risk factors of that 4-month baby. Kokap already mentioned this very well, because we also have similar religious marriages, for example, which may be a cofactor. So to know the baselines, we have some, of course, this is not an adult or like a teenager, so we should have the evoked responses and otoacoustic emissions. About otoacoustic emissions, Triyuda, do we have a preference about like distortion product or the other one?
Yes, sometimes the first time we have to know. The easier part is we have otoacoustic emission to check easily, maybe the short time. And then sometimes if there is some high frequency hearing loss, just we know that it's around the high frequency also will be can see in the data of the otoacoustic emission. Is that correct, Prof. Haldun?
Okay. Any other comments from the panel?
Yes, Prof. Haldun.
Jenny,
I'm Jenny
please.
yeah. So, in my opinion, that is right. We should have the baseline before we start the medication or the ototoxic medicine. Yeah, but unfortunately, we are in Indonesia, the oncologist, it's not yet. It's not yet aware of this. So sometimes they are consult to us. It's late. So we don't have the baseline of the hearing function, the test yet. So this is my homework. This is our homework in Indonesia, that we should give awareness to the oncologists and pediatric also and adult oncologists, that they should take the examination before they give the medication which is ototoxic. That's my opinion. So we have a lot of homework in Indonesia about this problem. That's
Yeah, you are so right, and this is a perfect comment. We should always be in touch. We should always be in cooperation with colleagues from other departments. All of us are working so hard. We have always a very crowded schedule to work on, and those people are especially the ones with using those ototoxic drugs are dealing with cancer patients. So they have many things to think of. But the cooperation and that collaborative effort will be, of course, even for the people that we are taking care of, our patients. So you mentioned the early cooperation, and I also want to mention one more thing about what Antoinette said. Actually, when you are dealing with oncological patients, you have a chance to make this before cycles. She already mentioned that the patient is so tired, sometimes not even cooperative enough, or we may have something temporary at the results that we can discuss. So you can do this before cycles. But for this patient, she is just 4 months old, and she is taking medication for tuberculosis. So it will not be a cycled one. And we mentioned about the baseline measurements, but when should be the second, third measurements during that period of treatment? Is it in weeks or months? I already see the hand of Kokap. Kokap, would you like to mention anything?
So I would also do the mitochondrial mutation in this patient. I don't know whether
I cannot hear Kokap.
Kokap, I can't hear you.
We cannot hear. Yeah, no.
Oh, I am. Can you hear me now?
Yes, but your voice was better when you were making your speech.
Oh, I didn't do anything. Let me just reset my. Can you hear me now? Right. Can
Perfect.
you hear me?
Now,
Yes.
now loud and clear.
Thank you. So I would do the genetic screening that Antoinette mentioned that we give to all the children who are receiving aminoglycosides. So I would do the A555G mutation. If the child is positive, then you obviously have to monitor them much more closely and avoid, where possible, aminoglycosides. And I don't know what other alternatives are there, But if there are positive, if they're not positive, I would still not be complacent, because I see majority of my patients receiving aminoglycosides are negative for A1-555. So that's one of the things. The second thing I would mention is, in addition to transient evoked, I would do transient evoked plus DPOEs. And there are DPOEs which go up to 10 kHz. Now, I was a student of Professor Camp, David Camp, who is the grandfather of OAEs. And there are possibility of going beyond, but of course, we are not looking at the mild hearing loss. When DPOEs disappear, we are looking at moderate hearing loss. But it's good to know if the 10 K is there or not. So you would be kind of pre-warned about the possibility of hearing loss affecting the speech frequencies. So these are the two pieces of advice, in addition to everything else that my colleagues have said, I would suggest. And I think it has to be done regularly, frequently, because she's high risk for hearing loss. She's, in my opinion, she is a high risk child. So if she is getting anything like gentamicin or streptomycin, which is awful, which causes other neurotoxicities as well, then she really needs to be monitored very closely. I would also give questionnaire to the parents to make them aware about changes in the behavior, because she'll be very difficult to test at this age for behavior testing. But observation from the parents, if she responded to, if she startled to loud noises before and she stopped doing it, that's an indication. Or, responding to sounds, responses to sounds as well have dropped. So in UK, we have a red book, which parents go through. So looking at the sounds the children responded, recognition of voices, as they are developing. I think Antoinette has something to say as well here.
Before giving the word to Antoinette Kakop, there is one question from the audience, actually from Iklima Wangari. He is asking that, can we use sodium thiosulfate to treat other drug-induced hearing losses like tuberculosis treatment?
There is no such evidence, but this is a discussion with, because sodium thiosulfate is it's like antioxidant, and the ROS is it's a toxic. This drug was developed initially, was given in cyanide poisoning. So the answer that I don't have an answer for you, but you can look or consider this, but it has to be really done very carefully, because you just want to make sure that the child lives.
Thank you so much. Antoinette?
Yes, what I learned about neonates is that they have a renal immaturity, and the function of the kidney is very important for this topic. So they are, as a neonate, already at a higher risk to get rid of this toxic substances because of the renal immaturity, and also the blood labyrinth barrier has an increased permeability in a neonate. So that is a second risk of a neonate. So what I can perhaps add, and what I have found, is if you have to give aminoglycosides now, it seems that a once daily administration is less nephrotoxic than a multiple daily dosing. So this may be perhaps a point, so that the function of the kidney is better, and that there should not be given diuretic drugs in combination. Perhaps this may be a little bit helpful to have a better kidney function, and that means to have a less ototoxic risk, because the ototoxic substances leave the body by the kidney. Yeah, perhaps a little bit helpful.
Thank you so much, Antoinette. I'm sure that we have many residents and young colleagues listening us, because we have a great audience with more than 500 listeners now. We have been talking about the ototoxicity of these drugs because today's topic is ototoxicity. But mostly these drugs are also nephrotoxic and neurotoxic. So we have many things to consider, actually. And a very nice question from the audience is that perhaps we can combine this with this case here. How we will be understand that this ototoxicity of inner ear is permanent or reversible? How long does it take for the inner ear to recover or regenerate? Do we have any comments from the panel?
Maybe Prof. Haldun, can I continue with the results?
Of course, please, Becca, please.
Okay, because of the time. So please slides. So this is the tympanometry result that show a normal tympanogram slide. And now this is the otoacoustic emission. And from the examination, we see no abnormalities of the outer hair cells in the cochlea in both ears, both the right and left. Slide. And also we did the auditory brainstem response, and the result is passed on both ears as well. So Prof. Haldun, maybe the discussion can continue with the relationship and the role of the systemic antibiotics and also anti-tuberculosis drugs in the ototoxicity. Regarding the results of the examinations.
Any comments from the panel?
Yeah, I think.
Please, Yeni.
Yeah, thank you. So I think because the doctors give the rifampicin, so it is more safe, yeah. So we don't see the problem yet in the inner ear, but we should continue to monitor with the hearing function, because we don't know, because they will give another medicine until the tuberculosis is released. So we should keep monitoring the hearing function. So in my opinion, in this case, because the medication is rifampicin, it's more safe than the others aminoglycoside, then the answer of this problem is the hearing function is still good. So we should monitoring this one, because if once the hair cell is induced by the ototoxic, then it will be more difficult to give a better hearing. Thank you, Prof. Haldun.
Thank you, Yeni. Any other comments?
Yes, Prof. Haldun.
Triyuda, please.
Yes, thank you. I'm agree with Prof. Yeni, Basirudin, that he said that we have to check the monitoring after give some medication. From the baseline, maybe we can see the hearing threshold is within normal limit. So we have to check regularly. Maybe not only when the best time to check the hearing threshold. Also, we have because the patient is 4 months old, maybe we have to know tool to see the earlier check before the hearing problem is there. We cannot use some like algorithm SIPs or blocks to see the problem with 20 decibel below or 40 decibel below, because the babies have to check often maybe, and also we have to check the progressive hearing loss if the ototoxis can be happen. Maybe that's a professor. Thank you.
Thank you. Any other comments? Ranga, would you like to continue?
Yeah. Okay, sure. So may I continue with the second case, Prof?
Yes, please.
Okay, so this case, the second case, is a little bit different. The clue or the topic is the relationship between ototoxicity and chemoradiation regimen. So this case is a 21-year-old female with a complaint of tinnitus after 3 cycles of chemoradiation. Slide. So this patient is diagnosed with nasopharyngeal carcinoma with the stadium T2 and 3M0 and was given chemoradiation with cisplatin weekly 5 times, 5 cycle, and also radiation 70 gray. And after 3 cycles of chemoradiation, the patient complained there is a sensation of ringing in both ears, but no complaint of vertigo nor hearing loss. Slide. So the examination slide. The result, we see the normal tympanogram in both sides, slide. And then from the acoustic emission, we found the abnormalities of the outer hair cells in the cochlea in both ears, both left and right, especially in the high frequencies, slide. And this is the serial audiogram that we made. So the first time is still have a normal hearing threshold, but there is already a reduction in the high frequency. So this is after the 3rd cycle, and after the 4th cycle, it's still normal hearing loss, but with also reduction in the high frequency. And after the 5th cycle of chemoradiation, still the same normal hearing threshold, but with the reduction of the high frequency. But as we can see here, there is we did also the tinnitus matching in this patient, and we saw the tinnitus was on the 6 kilohertz frequency. Slide. So after the 3rd cycle, the first time, the pitch matching was a white noise with a loudness of 40 decibels, and then the residual inhibition is 80%. After the 4th cycle, the pitch 4th and 5th cycle, the pitch matching was 6 kilohertz with the residual inhibition of 70%. Slide. So I think that's the second case, Prof. So this is a case of a patient with NPC after chemoradiation has a complaint of tinnitus and high frequency hearing loss also in the audiogram.
This was also a nice example case, Ranka. Thank you very much for the case. So who would like to have the words from the panel?
Yes, Prof. Haldun.
Jenny, please.
Yeah. So this is unfortunately because we don't have the base before the cycle. Yeah. So that's why. Again, this is 500, almost 500 ENT here. So please remember that before we did the medication, which is ototoxic drug, then we should do the baseline of the hearing, because in this patient, this is the 3 cycle. Then because of the patient complaint of tinnitus, then the doctor sent to us to the ENT to do the hearing function test. So actually it's a pity because we don't know exactly whether this patient have a normal hearing before the ototoxic. That of course we know that after the 3 cycle of ototoxic medicine, the hearing loss they have the hearing loss in high frequency. What we don't know yet, because this is 21st years old patient, we don't know exactly whether before they got the medication have a normal hearing. Because on the 21st years, sometimes they get the noise-induced hearing loss, or we should know exactly before the cycles of ototoxic medicine. That's my opinion, Prof. Haldun. So I want to emphasize for the all ENT here, 500 in Indonesia, we have big homework to make awareness to the others colleagues, which is deal with the ototoxic medicine. Thank you.
Thank you so much, Jenny. Excellent comments. Any other comments?
Yes, Prof. Haldun, thank you.
Triuda, please.
Yes, thank you. As we read that the presentation that cycle 4 and cycle 5 is almost same result. There is already have a hearing loss, but when we have to check regularly, is there any possibility to reduce the hearing loss after we finish the treatment or the chemotherapy, or we can wait until maybe 2 months, 3 months, or 6 months that in the journal that I have read. Maybe there's any possibility to have back the hearing after we finish the hearing, after finish the treatment. So we have to check, or else we have to give some hearing aid for the high frequency maybe for the after the treatment. So until we can give some hearing aid, is there any possibility to give some immune system therapy that's maybe in our country is natrium thiosulfate is not often to give to the patient like this. Maybe this our comment, Prof. Haldun.
Thank you very much for that comment. Any other comments from the panel?
This is Kokub. Unfortunately, I don't see people at the age of 21. Most of the children are under age, but can you show us the audiograms that you have, one slide with all the hearing tests? Because I have a feeling that the hearing deteriorated between cycle 3 and cycle 4.
Okay, can you show the previous slide, please? And yeah,
that's
this
it.
one. Yeah.
So if you look at the hearing test, there is a there is a change, slight change, isn't it? No,
yes.
There isn't.
So minor, I assume, huh?
Yeah. So there is some deterioration from, I can't tell because the first audiogram is faded, 29th of December, 2023. And the one that you have seen, the number 3 is 10th of January, 2024. So there is a very short period of time between the audiogram. It's like less than a month from looking at it. So why did you do hearing tests so quickly? I mean, what kind of cycle there? So she's having quite a lot of
Yeah.
in a short space of time. So I would monitor her hearing quite closely because sometimes the hearing loss may not be what we find when we see them. So that, she's an adult, so I don't have much experience, but if it was a child, I would want to see this child quite soon after the completion. And how many more cycles did she require after the 5th cycle? Do you know?
Yeah. So actually this patient is going through 6 cycles. So maybe one more cycles.
One more cycle.
Yeah.
So you should have tested her again because the last test was done on 10th of January. So she must have had some further tests since.
Yeah.
So you don't have that.
We don't have the data yet, but this audiogram was made after each cycles, and although the hearing threshold is still the same, but we saw a shift of the tinnitus matching frequencies and the loudness as well.
Yes. So, so ototoxicity is not a, one-time episode. It can be progressive, as Antoinette mentioned.
And it can be, she's not out of the woods yet. You need to monitor her hearing further and manage her tinnitus and possibly some hearing tactics and maybe, you know, she, right now, I wouldn't say she's a candidate for a hearing aid. I don't know. Antoinette, do you think she's a candidate for hearing aid? We wouldn't be.
Yes, yes, maybe we have to try because there are also patients who do not like to wear a hearing aid, or
Yeah,
yes, it's difficult to do the hearing aid supply. I'm very happy by this case because tinnitus is mentioned, and
yeah,
when we think of ototoxicity, mainly we think of hearing loss, but tinnitus
no,
is also a big problem because for the patients it's really awful to have tinnitus, and until now there are not many data about tinnitus after platinum products.
Actually, this was a very nice example, Ranga, because although we don't see any hearing loss yet, let's say it's still in the normal hearing threshold level, we can see that progressively her tinnitus is increasing, so her quality of life is decreasing. So we have a nice question here at the Q&A. What should we do? Should we adjust the dose of the platinum here, or should we prescribe anything like steroids to decrease the potential of hearing loss in the future, or hope for a relief for tinnitus like steroids or adding antioxidants? Do you have any comments for this?
Yeah.
sorry,
please.
can I mention,
Okay,
go ahead, Prof. So I would not even consider giving any steroids. I mean, I don't know, that's for the oncologist to decide, but that's not a good idea, steroids. So number one. Number two, obviously, you know, it is again not our decision. We are monitoring the hearing. It is not our decision. It's the oncologist's decision to either reduce or change, because you don't want to compromise their life expectancy. So if they can lead a normal life with higher dose of cisplatin, reducing the dose of cisplatin is going to compromise their life expectancy and the efficacy of the treatment. So that's, again, something that oncologists need to discuss. We can, if it's not sodium thiosulfate or any protective agent are not being tried. There are examples in adults in US studies, but we have not had the license to use it in adult at the moment. But it's definitely not indicated if there are metastatic tumors. So if she has a metastatic cancer, no way would anybody approve, even the company would not supply the medication. So I think at this stage in time, you know, I don't know what choices are available in Indonesia to protect the hair.
Haldun?
Yuda?
Yes, can I ask to the Dr. Kokap, can we wait for the next hearing test after the sixth cycle?
Absolutely, yes. She
So
must have had her sixth cycle now.
Is there possibility to the hearing loss is getting better, or we can wait until 3 months or 6 months?
I don't know. I do find that in children sometimes we do see improvement in the responses, but I personally think if we are doing a behavior test, it may be because the child is paying more attention, you know, is much in a better mood. An 18-month-old can have, they have a very strong opinions that if they're not going to cooperate, they're not going to cooperate. That's it. So, but do we see these improvements in children who are older, who we can reliably test? Very rarely.
Okay, thank you.
I mean,
Thank you
Antoinette,
so much.
you need to comment here as well, please.
Any, Prof. Haldun?
Yeni,
Yeah.
please.
Yeah. So, in my experience, we should concern about the complaint of the tinnitus. So, we should give explanation and education to the patient how to manage their tinnitus. So, usually we do the tinnitus retraining therapy, so they can adapt it with their tinnitus. But sometimes we also give the antioxidant drugs, yeah. But we don't have any experience to give such a patient with the steroid. So, in my opinion, as ENT doctor, we should concern about the tinnitus. That's my opinion. Thank you.
Thank you so much, Yeni. Dear friends, unfortunately, as every beautiful thing, we have an end for this beautiful webinar today. It was my pleasure to moderate this last session with my dear colleague Ranka. So before closing, I would like to thank again to all of the parties that have contributed for the success of this meeting. And I will leave the last word to my young colleague to make the closure. Ranka?
Okay, thank you, Prof. Haldun. So from these two cases, we can see the highlight of the relationship between ototoxicity and also the administration of antibiotics, and also chemotherapy and also radiation therapy, which is also almost as important as the chemotherapy as well. And what is important is to have a baseline data and also a careful and detailed monitoring, because we know that our patient really needs the antibiotics and also really needs the chemotherapy and also the radiation. So we need to have a baseline data and also a close monitoring to see if there is any ototoxicity, then we can address the ototoxicity so the patient can have a better quality of life. I think that is the highlight of the discussion, Prof. Haldun.
Yes, thank you so much. So thank you very much to all the panelists, to our speakers, Antoinette and Kokap, Yeni, Triyuda, Rashid, Antoinette, thank you so much. It was a pleasure being with you today, and I hope we will be together in many other meetings with our Indonesian colleagues and in the meetings of Union of European Phoniatricians. Thank you very much.
Inshallah. Thank you.
Okay, thank you.
Thank you, Prof. Antoinette, Prof. Rashid, Prof. Kaukap, Angga, and Rangga.
Okay, thank you, Professor Haldun, Dr. Rangga, and thank you to all our panelists. We have now reached the end of our webinar. On behalf of the organizing committee, I would like to extend our heartfelt gratitude to all of our speakers for their valuable contributions and to all participants for joining us today. We hope you found the webinar informative and beneficial. We'll see you soon again at the next webinar event. Wassalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum.
Waalaikumsalam.
Thank you, everyone.
Thank you very much.
Thank you
Prof.
very much.
Haldun, Prof. Antoinette, Dr. Kokap.
Sampai jumpa.
See you. Prof.
Sampai
Yeni,
jumpa.
Dr.
Assalamualaikum
Angga, Prof.
warahmatullahi
Rashid.
wabarakatuh.
Terima kasih.
Thank you,
Terima
guys.
kasih banyak.